My name is Dr. Joanna Chan, and I work in SGH Emergency Medicine Department. I'm also a member of the Advanced Care Plan Work Group in SGH, and I advocate for mental care for geriatric patients. Today, my talk is addressed to two groups of people. The first group is the group that looks at an older patient and thinks, wow, should I really do CPR on this patient? Am I going to make a difference? Am I doing something wrong? And the second group of people who need to hear this talk is people who think that I need to aggressively save life at all costs for all people. So the answer lies in balance, and this is what I'm going to be talking about today. So first, I'll be going through a brief summary of atypical presentations of illness in the older person, and some FAQ on CPR in older people, some practical considerations, and what first responders can bear in mind. And I hope to touch briefly on the concept of advanced care planning and DNR. So in Singapore, the rates of out-of-hospital cardiac arrest in older persons are increasing. The average age of an out-of-hospital cardiac arrest victim was 70 years old, and the median age was 73 in 2021. Meaning that as a first responder, if you respond to the My Responder app or you're paramedic, you rush to a cardiac arrest case, the face you're looking into is usually an older person's face. And the rate of cardiac arrest in older people, like for example, those over the age of 90, has actually tripled between 2011 to 2019. This reflects the rate of our aging society and the fact that people are living longer and longer. In Singapore, what is OHCA survival? So this is a graph that shows collated figures for all scenarios, meaning people who may have been discovered immediately or much later, the people who advised standard CPR and people who didn't. So the collated rates in general for older persons was 2% in 2021 versus 7.4% survival in the less than 65-year-old age group. But to be noted, this is not the old time reporting, where if you have the best case scenario survival, where there's a shockable rhythm, immediate bystander CPR, AEDQs, actually survival rates are more than this, about 19% overall. So that brings me to the fact, why is there such a big gap between the overall survival rate and the best case scenario survival rate? And the reason is that because most cardiac arrests in older persons are actually not due to heart attacks. In many cases, they may have non-shockable rhythms, and the survival rate in these cases is much lower than if it was a shockable rhythm due to a heart attack. And why is the reason that cardiac arrest occurs? Is because when older people, if anyone gets a severe infection or surgical emergencies like bowel ischemia, changes to the blood acidity, this can cause an overwhelming acidosis, there's electrolyte imbalance, and the heart may stop beating because of this. Some older people have chronic organ failure. They may have reduced capacity in the lungs because of COPD, reduced capacity to clear toxins in blood and urine, and pump failure due to heart failure. So when they get emergency illness, an acute illness, it can tip them over into cardiac arrest. What about if there is a true heart attack? For example, in a STEMI, blood vessel of the heart gets occluded acutely due to a ruptured cholesterol plug or a blood clot. So this may trigger off an electrical arrhythmia, which will be amenable to shocking with an AED. And in these cases, survival rate is good if you can detect it early and shock early. But in the older person, they may also present atypically. So they may not present with chest pain per se, they may present with breathlessness. And sometimes in the older patient, they have difficulties in communication, they may have cognitive deficits, and they have difference in pain perception. So they may not be able to say that they're not feeling unwell, and sometimes these cases may also go unrecognized. So what are some signs that an older person is not well? Regardless of whether it is a cardiac condition or a non-cardiac condition, where they're having an acute illness, it could present like this. It could be a feeling of fatigue. Normally, they like to clean the house, but now they can't do housework. They can usually watch TV every morning, but today they decided to skip it because they couldn't even get out of bed. They need more help, not their usual self. Appear to be breathing very fast, even if they do not complain of breathlessness. No appetite, not eating. The caregiver may have resorted to actually feeding them, even though they can normally feed themselves. And there may be a change in personality acutely over these 2 weeks rather than over months to years. So it's important to recognize these signs of potentially severe illness so that we can prevent and bring them to the hospital before the cardiac arrest occurs. Because prevention is always much better for survival rates than to wait to the point that the patient has already collapsed. Okay, so frequently asked questions for CPR in the older person. Why should we be doing CPR? Does bystander CPR really make a difference into survival? And can they return to normal life after surviving CPR? Are there also situations where it may cease to be useful? So what is the reason for CPR? Just to recap basic principles, CPR preserves circulatory function in the body while the heart has stopped beating to bring oxygen to the brain to try to maximize the chance of neurologically intact survival. So we hope that even after the cardiac arrest has resolved and the heart has started beating again, the brain will not have suffered damage from lack of oxygen and the person can go back to their activities of daily living and preserve independence as much as possible. So there are some cases where you will not be able to reverse the cause of cardiac arrest, meaning that even though the heart has stopped beating, we cannot reverse it and make it start beating again, such as in cases of cancer, advanced organ failure, and so on. In these cases, CPR may be futile, but of course, as a first responder, you will not know. There are some other patients who may have weighed the benefit of CPR with the trade-offs of survival. So I will cover this in more detail later on, but they may have opted out based on their personal knowledge of their medical conditions as well as their values and what constitutes minimum acceptable quality of life to them. However, if you're a first responder and you don't know anything about this patient, you should proceed with CPR because CPR is time sensitive and can be life saving, and it is the best shot at neurologically intact survival. We should follow the principle ethically of choosing the path which offers most flexibility until more information is available. When unsure, let other providers down the line take the decision to stop. But if you're the first at the scene, you can resuscitate first with no guilt. So, as mentioned, the first responder will not know the patient's premises, whether they have existing chronic conditions that render CPR futile, whether or not it's going to be a shockable rhythm or not. You won't know until you put the AED on. So, act first, push hard and push fast. So, the first responder will not know whether this patient belongs in the subgroup of patients who will survive very well with good outcomes, or in the subgroup of patients who may not survive well. But it is correct to perform CPR unless information is immediately available from a trusted source that the patient does not want CPR. So what are the ingredients for the best case scenario that will maximize the person's chances of neurologically intact survival? It should be a witness arrest. And the truth is that many arrests in the home are not witnessed because the patient is found lying on the bed and may be discovered some hours later. So that's why statistics in Singapore show that it's actually arrests that occur in public which have faster response time. So bystander CPR and shockable rhythm with an AED applied. So these maximize the chances of survival. And what is the survival rate of CPR in out-of-hospital cardiac arrest? So if you watch TV gives you a very optimistic picture. So that someone who actually watched all episodes of Grey's Anatomy and House and counted the number of times CPR was done. So of this, 70% survive, and of those who survive, another 70% survive to hospital discharge. This is an unrealistically inflated picture of the effectiveness of CPR. But however, there is some truth that CPR is beneficial. So while we moderate our expectations, let us not discount the benefits of doing CPR. So in Singapore, our hospital statistics show that in general, those who survive, overall, 80% survive to admission and 5% survive to discharge. The rates of survival are higher in the younger age group. So as you can see, less than 64 years old, about 23% survive to admission and 8% survive to discharge. And of which overall 6% survive with good neurological function. So CPC stands for Cerebral Performance Score, meaning the patient is cognitively intact but may need a bit of assistance, may have a bit of deficits such as seizures, but is able to function well. So if you see the older age group, in those who are 65 to 80 years old, actually survival to admission is 18%, and survival to discharge is 4%. If you go to the super aged group, more than 90 years old, survival to admission is 6.1%, and survival to discharge is 0.8%, meaning that for every 100 more than 90-year-olds on who has out of hospital cardiac arrest, actually one will survive. So the chances of survival are not nil even with advanced age, and you can have a chance to save a life when you do CPR in out of hospital cardiac arrest. You can see that actually 4 of these individuals survive neurologically intact. So yes, bystander CPR increases neurologically intact survival regardless of age. This is the paper that diagram was taken from. And over time, actually, as more and more bystander CPR is being done in the community, the rates of neurologically favorable survival is actually increasing, even in all age groups. And you can see that those in the 65 to 80-year-old age group, the numbers are all going up. The same paper also plotted a projection of difference in survival rates between best case scenario and not best case scenario. So best case scenario means witness arrest, bystander CPR, AED use. And there's a huge, statistically significant difference in survival. You can make a big difference with immediate good quality CPR. Regardless of the how old the patient actually is, all the way up to 95 years old, the confidence interval does not overlap. So what about non-Singaporean studies? So same thing. Okay, bystander CPR gives you a higher likelihood of survival to hospital discharge and a better rate of neurologically intact survival. And age itself, in absolute terms, is not as significant a factor for survival as compared to whether there are the ingredients for the best case scenario, meaning whether it's a shockable rhythm, witness arrest, and CPR delivered. Not just do they survive to hospital discharge, they also survive for 5 years beyond hospital discharge. So CPR is never futile even in an old person, regardless of how old they are in absolute terms. Outside Singapore, the figures are similar. I just put this on slide to give you an idea. You can see that there's shockable rhythm. Survival can be in double digits, even for above 90-year-old age group. So in the first point, 20%, 15%, and 11% survival for people with shockable rhythm, even if age group is above 90. That's the last category. In-hospital CPR has even better survival rates, logically. So even patients who are 90 years old and older, they can survive to the tune of 11%. So survival is in double digits, which should reassure us practicing in the hospital that when a very old person collapses, the efforts to be made are life-saving. That said, not every survivor's family takes a positive view of the long and laborious journey of recovery after CPR. So some qualitative studies have been done. And in one case where out of 47 cases of arrest, 5 survived, only 2 out of 5, only one family took a positive view of the journey, and 2 out of 5 formally independent patients had to go to a nursing home. So what are the trade-offs of CPR? This is the other group that I was addressing, those who believe that CPR must be done in every patient. There are good reasons sometimes for not doing CPR, and this typically takes place after a nuanced and complex discussion has already been held with the patient and the family to define what constitutes good minimum quality of life for them and what situations in which they would prefer not to be resuscitated. So as you can see, everyone has got a certain minimum quality of life acceptable to each individual as represented by the red line. For us, when we are young, our baseline function may be high above this red line, and when we fall sick, the doctors will not hesitate to do CPR on us and intubate us because they reason that our physiological reserve is good enough that we can bounce back from the recovery period, even after a prolonged stay in ICU, even though we may need to learn to walk and talk again in extreme cases. There's a high chance that a young person will still be able to recover and still have a meaningful life after that in the first graph. The second graph, however, shows the case of a frail older person. maybe somebody whose walking function is not so good, as illustrated by Dr. Christian earlier on, where the baseline function, if they go through a very stressful period in the ICU, if they receive CPR and intubation, subsequently they will not be able to recover back to that baseline level that keeps them living a meaningful life, but instead their quality of life drops below what they consider acceptable. So they may have to be dependent on other people, or they may have to be dependent on feeding tubes, they may need a lot of assistance and may not recognize their family members. In these cases, actually, when doctors weigh the minimal quality of life acceptable to them with the features of their disease state, they will make a medical recommendation, and they will tell the patient that they may want to consider not opting for resuscitation if cardiac arrest occurs, because they do not want them to live a life that is not meaningful. So, are there circumstances when CPR ceases to be useful? So yes, a patient who has known chronic organ failure or cancer in the terminal stage may not have additional survival benefit conferred by CPR. A patient who is independent but has very poor reserves due to frailty may not wish to undergo the resuscitation process with slim survival benefit and high chance of functional dependence post-resuscitation. Age alone is not a good predictor of outcome, as opposed to patient physiological factors, how frail they are, and disease factors, what are the chances of survival expected from their current disease state. But survival does drop with older age. So this answer differs for every person in terms of both medical recommendation made by the doctors with an understanding of their medical condition, as well as the patient's own values, which defines their red line, how high or how low is the red line, and where would their threshold be for choosing not to be resuscitated. And I had put the illustration of the clinical frailty scale again because this decision needs to be revisited as the patient changes at different points of the scale. Do patients change their mind about CPR when they find out that the probability of survival is lower than they initially thought it was, as influenced by maybe Grey's Anatomy and House? So this is an old study that was conducted in 1994, when initially, when patients were asked if they wanted resuscitation during acute illness, 41% said yes. But when they were told that survival rates were about 10 to 17%, then half of them opted out, yeah, and didn't want to have CPR done. And for those who were known to have a terminal illness with low life expectancy, initially about 11% said yes, and then subsequently half of them opted out when they were quoted a figure of 0 to 5% survival rate. So, as the first responder, just to reiterate, you cannot have these complex and nuanced discussions when the patient is already in cardiac arrest. So, remember my earlier slide, if you are lacking in information, just do CPR first. So, what are the practical tips to be mindful of in older people? So once you have established that CPR is the default action, in absence of other information, follow the DRS ABC algorithm, get an AED. Remember that AED is the component of the best case scenario to maximize the patient's chances of survival. So push hard and push fast. Remember to depress the chest to 4 to 6 centimeters and allow full recoil. So you need good quality CPR. You cannot do half-hearted CPR because you want to maximize their neurologically intact survival chances. Okay, breaking ribs can be an unavoidable outcome of good quality CPR, but if the casualty dies, it's not because you broke their ribs. And AED use, okay, so if the patient has an ICD, which can be on either the right or the left, paste the sticky pads 4 finger breaths away from it. And if a patient has a drug patch, remove it to stick on the pads. So sometimes you will see these kind of drug patches. These are reverse stigmin patches for mild dementia, and then maybe other kinds of drug patches as well. So be prepared that ribs will break because in an older person, their rib cage is less flexible. Don't be alarmed. This is part of the life-saving process and is the least of the patient's worries. Sometimes as a first responder, you will feel very alarmed when you feel the ribs cracking. So just do it. Recognize that you did your best with limited info. It's okay. And accept that when you replay this memory in your mind, you may have mixed feelings about it, and that's okay too. Yeah. So summary of the part one of my talk. Cardiac arrest can occur in acute or chronic illness. Early recognition of illness is important because prevention is always better than response to arrest. Age alone cannot be used to decide whether CPR is useful or desirable. Ideally, a thoughtful process of discussion, customized to each individual's values and medical situation, should already take place and be documented before the crisis. If in doubt, resuscitate. Bystander CPR improves outcomes no matter how old the patient. And CPR outcomes are best in shockable rhythm cardiac arrest, which occurs outside the home, and when CPR and AED are used together. First responders should be prepared to use an AED. So CPR principles are the same in older people. Good quality CPR preserves neurological function. Push hard and fast, be prepared that ribs will break. And CPR outcomes tend to be worse with frailty, known chronic organ impairment, and known end-stage chronic illness. So patients who find themselves in these positions may need to consider whether they want to write down their wishes so that it's clear to their family members if cardiac arrest occurs what their wishes are. And so I'm going to be touching briefly on some of the end-of-life documentation formats available to members of the public. Felicia after me is going to elaborate more on AMD and LPA, so I won't go into so much detail. But basically, AMD is of limited value in acute emergency situations because it can only be accessed during office hours and when the conditions are already met. LPA is an important document that everyone should do if you want to appoint someone official to manage your estate after you lose capacity, for example. Okay, in the hospital setting, what I find most useful as an emergency medicine doctor is the advanced care plan because this is a statement of the patient's wishes and values. So basically, it's a document that helps to document the red line, the position of that red line, the minimum acceptable quality of life in relation to the current disease state. And that helps doctors to be able to make correct medical recommendations that are in line with the patient's values and wishes. So in the event that you cannot make these decisions for yourself, these previously expressed wishes will help to guide treatment decisions. Doctors should inquire after the patient's wishes in any case, whether or not this document exists. So this document is just a helpful record of their wishes, but if they have also entrusted their wishes verbally to the family, that also acts as a verbal remembered record of what the patient wants. And the term "do not resuscitate" is actually administrative term that should be used by the medical team for care provision purposes. So if after speaking to the patient about their preferred plan of care, the doctors need to write down for their team members to know so that everyone's on the same page that this patient wishes not to be resuscitated. They will write a note to say DNR in the medical record so that when the night team comes on, the on-call team comes on, they will all be on the same page and they will still know what action plan to take if the patient does suffer a deterioration overnight. But DNR is jargon. It should not be used in communication with patients because the sound of it does not sound very compassionate. It's actually just an action plan to tell doctors how to act, but it's not something that should be used in communication with family. Okay, so these are some examples of what the documents look like. So AMD is a legal document which is stewarded by the Registrar of Advanced Medical Directives and which most ordinary doctors are not able to retrieve. LPA is a legal document where you confer your powers of decision making to someone else that you trust, who should actually also be a nominated healthcare spokesperson for the ACP in that case. The ACP can be made by anyone in any stage of health. It's usually done with the aid of a trained facilitator, like a medical social worker or a doctor. And it is signed by the patient themselves as well as their nominated healthcare spokesperson who can use this document to guide them if the patient is not able to speak for themselves. It provides a voice in the room of the patient, reminding the doctor and the healthcare team what is their minimum acceptable quality of life. So this is what the this is what the general ACP looks like. Actually, nowadays you can make your own one on mylegacy.gov.sg, and it will be emailed to your nominated healthcare spokesperson, and everyone can sign electronically with SingPass. So if you're confident to be able to write this in free text on your own, you can actually go ahead. If you prefer a facilitated discussion, you can make an appointment online to get someone to take you through it. So you will be able to write in free text actually what defines joy for you, what helps you when you when you face serious challenges in life, any fears or worries you have about your illness, and what's important to you if your condition changes. Yeah. So this will greatly help your surrogates if you need to have them to make decisions for you. So it also gives a scenario where you're cognitively impaired, in which case what would the goal of your care be? You can choose comfort, trial of treatment, and I'm not ready to decide. Okay, and then you can also specify your own footnotes, like I don't wish to have any tubes inserted in my body. And then it will be signed by yourself, your nominated spokesperson. So if it can be spouse, it can be child, but in some cases it may be friend if the owner person is single. Okay, and then there are certain documents that help to facilitate more specific discussions for people who have known specific organ failure and other illnesses. So I would like to end off with a question. Would you do CPR for this person? So this image shows someone who has got a tattoo that says "Do not resuscitate," which a lot of young doctors joke that they will get once they are past the age of 17. Okay, so actually, you do not know the circumstances under which this tattoo was made. How do you know that it was made when the patient was of sound mind, not intoxicated? Maybe he did it as a joke when he was 18 years old. He just never got around to erasing it, but his views have changed since then. There's no signature, there's no surrogate decision maker contact number there to call. So you cannot verify whether this is the patient's current wishes at this point of time. So please proceed to resuscitate. You will not get into trouble. An ACP document is more useful than this tattoo. So in conclusion, what I've shared is that ACP is very useful. It gives you a voice in the room if you cannot speak for yourself one day. And it gives your nominated spokesperson peace of mind and guidance. So ACP can be revisited and revoked at any time. It's actually the doctor's duty to ask your nominated spokesperson whether the ACP still holds, whether you've changed your mind. So it's basically the last known place on the map. But the doctor still needs to now mark out your new place on the map based on how your condition has changed and whether you have changed your mind about anything. So doctors should also take specific medical circumstances into account and make recommendations about treatment based on that. Do make your wishes known to your loved ones and let them know where to find the ACV document if you have made one. And the AMD, in my experience, is of limited real-life, real-time application for doctors. LPA is important for administrative reasons, and the LPA donee should logically be the main spokesperson. So I hope I have answered the views of the two camps of people. So just remember that for people who wonder whether it is worth doing CPR on an older person, I have quoted some figures that show that survival can be in the double digits, even for people who are more than 90 years old, if the best case scenario is met. So you will not know whether the patient has shockable or non-shockable rhythm. Just be prepared to do CPR, push hard and push fast. Don't worry about breaking ribs, and be prepared to use an AED. And for those who believe that life must be safe in every situation, I would like to remind you that sometimes advanced care plan wishes have been documented, and we should try to respect them because ideally everyone should have gone through a thoughtful process of contemplation about what they wish, and CPR is no longer the default option for people who have already gone through this thoughtful process.